So this patient, a little more interesting than our other glaucoma suspects. So this is a 65-year-old black male, comes in complaining of near blur, ends up having great vision with the refraction. IOP is borderline, dilate him, and he has moderate cupping. But the big thing is he has this little disc heme. At this point, I was working with fourth-year students supervising, and unfortunately, the student did miss it, but luckily I caught it without the fundus photo. So we know that on the OATS study, 83% of these disc hemes were missed clinically. And these are glaucoma specialists that knew they were in a research study, so they were really trying really well to examine their patients. So they're missing the huge bulk of their disc hemes without fundus photos. It's like, what hope do us regular docs have, you know?
Again, it's another reason why we really need to continue to take disc photos. I think disc photos are so important.
Yeah, I think because OCT and visual field has gotten so good that
Yep.
fundus photos have sort of fallen out of favor, but I get them on all my glaucoma suspects, or at least I try.
Yeah, it's one of those things where with my glaucoma micro-credential students at the college, one of the first lectures that I gave them really dissected the optic nerve. Because really when it comes to glaucoma, it is a disease of the optic nerve, and you really have to look at the optic nerve. So getting good at analyzing the optic nerve is imperative. The more that you tend to do so, the more likely you are to pick up some of these things like disc hemorrhages and not. Unfortunately, as we're going through and doing our examinations, we've been so ingrained to think about CD ratios that we only look at that center portion of the optic nerve, and we sometimes don't branch out. And sometimes disc seams are right at the edge like that, or sometimes even just slightly outside of the cup or the disc. And if you don't kind of move your eyes out that way, you'll absolutely miss it. So, great pickup.
Thank
I
you.
can see that you're better than students.
Yeah, that's good. I mean, this heme, you look at it, it's really almost camouflaged with those
it's a
blood
tough
vessels
one.
right there. It's really tough to pick up.
Yeah, that's a really tough one.
So of course, this is a glaucoma suspect, and they're coming back for the full workup. About 4 weeks later, this patient shows up, pressure 24/21. So remember, the right eye is the one with the disc heme, so that's the one we're really worried about. Packs, maybe thin average, but nothing too thin. Gonio was open. And again, first thing I look at is the quadrants. Everything looks fantastic in terms of colors, but look at that huge asymmetry. And the asymmetry, 114 in the right eye versus 156 in the left eye, that really corresponds really well with the disc heme that we saw and the bigger cup in the right eye. And that, of course, also corresponds with our deviation map, with our T-SNIT asymmetry, and our average RNFL thickness asymmetry. So this is what we were talking about before, where even though the quadrant is green, you can clearly see that RNFL defect, even though you might not see an RNFL defect clinically, but that's right where that disc heme is. So this is why I love the Zeiss deviation map, that without that really sort of red and yellow highlighted, it might be a little bit tough for you to tell, unless you're really looking at these asymmetries between the two eyes.
Yeah, it's kind of interesting. Now, this is where we differ a little, because I don't spend a lot of time looking at the quadrants. The deviation map is the heat map deviation map, and then looking at the symmetry of the T-SNIT curve, because you can clearly see as you circled it there, that inferior section, there's a big difference between the right and the left eye. That solid line, which is that right eye, there's a huge dip or deficit, which requires investigation. So yeah, great pickup.
And of course, we get our visual field. And the visual field corresponds pretty well. So you have that superior nasal step correlating with our thinning on the RNFL. That's really picked up pretty well the deviation map and our T-SNIT curve. And of course, with that disc heme we saw. So with this patient, I think we can say this is definite glaucoma. We have correlating data there. Ideally, I always like to get 3 IOP checks. So I actually had this patient come back in about 1 to 3 weeks to get another IOP check, but I told him, look, you're coming back, but you're starting treatment no matter what. So he was already set up for it. And I think his IOP was about the same. This sort of lets me know what his Tmax is and how to develop his target IOP.
And I think you actually bring up a good point. Throwing this all at a patient at once can be sometimes overwhelming. So what I do like to do is I like to show the patients the data, look at the findings here that I have, talk to them about their pressures and their visual fields. And then I say, really our next steps is some sort of intervention, whether it be eye drops or whether it be laser, some sort of intervention. And, I say, well, why don't we get one more eye pressure check, and it lets them ruminate a little bit, it lets them think about, their condition a little bit, so that when they do come back in, they're already expecting some sort of treatment, whether it be drops or an SLT. So, we're at a point where the patient has really come to terms with it. So sometimes it can be very overwhelming, all of this at one single visit. And I like the fact that you kind of split this up, because that's exactly what I do.
Yeah, that's a good point. From the patient's point, it's sort of the
Yeah.
psychological aspect of it. It is a lot of information for them. And this is, again, a lifelong disease. This guy's relatively young, 65 years old.
Sure.
So let's say he has 20, 30, 40 years of treatment ahead of him.
The other thing to consider is that, when you hear about things like glaucoma, or if you Google things like glaucoma, it is a blinding condition, and people automatically, think that they're going to go blind. So, I think that, after you make the diagnosis, I do spend a lot of time talking to my patients saying, hey, you know what? This condition is treatable. We can treat this, and we can make sure we can do our best to ensure that you have good, functional, useful vision for the rest of your life. I'm definitely going to work with you. You need to work with me. So when we do start putting you on some eye drops or medications, I do need you to come back in for your follow-ups. I do need you to take your medications as prescribed, and together, we can make sure that we maintain your vision. And I think that's that team approach. So me and the patient, that team approach tends to increase compliance, tends to increase patients coming back and being more fruitful with their medication. So,
yeah, that's a great point. So, once a patient has glaucoma, we have to sort of grade it. And the Academy and American Glaucoma Society and sort of ICD-10 way of grading it is going to be here on your left side, where they have mild, moderate, advanced. It's a little bit different than what I think we do clinically. I use the Hodat-Parrish-Anderson criteria a lot, where it's also early, moderate, and severe, but this is based on more on the mean deviation of your visual field and the sensitivity of specific areas on the visual field. The criteria on the left side, this makes more sense, of course, for billing, that's what you got to do. But in terms of visual function, so mild or early patients, they have no visual field defects. Moderate patients have defects only in one hemifield, and then advanced, of course, is anything worse than that. So it does make sense in one way, but then a lot of our landmark studies, they didn't really use something close to that. They used something more similar to maybe the Hodat-Parrish-Anderson criteria, or there's other glaucoma severity score scales out there.
Yeah, absolutely. So, I think it's one of those things that, from an academic standpoint, this is what we teach our students. We talk about the Hodat-Parrish-Anderson grading systems. And I think it is one of the things that when it comes to classifying glaucoma, from an academic standpoint, that's really what our students know, really what our students learn. But when they do get to me in their 4th year of clinic and they're in my glaucoma service, I usually sort of show them the Academy of Ophthalmology and the AGS grading scale, because as you can see, it actually does talk about the ICD-10 codes. And for most students, and I think for most practitioners, it's an easier approach, because it's just a couple of bullet points. So for mild, you have the optic nerve abnormalities, but with no functional vision loss on a visual field test. For the moderate, you have the optic nerve abnormalities, but you also have visual field defects in one, hemifield that's not within that central 5 degrees of fixation. And then the severe is within central 5 degrees of fixation, or loss in both hemifields. So from a conceptual standpoint, I think for a practicing clinician, that might be an easier grading system. But when we do all our studies, and from an academic standpoint, the Hodat-Parrish-Anderson is probably the way to go. That little sheet that you have, I print that off and I keep it in the clinic, because as you can see on the bottom, it also has the risk factors for open-angle glaucoma suspect. And just like you mentioned it, less than 2, low risk, greater than or equal to 3, high risk. So again, it's a good visual on your busy clinic.
So what do we follow up our glaucoma patients? And that really depends, are they stable and what severity of disease they have. But even though we have these guidelines from the AOA, the big thing to know is that they need a DFE, they need an OCT, they need a visual field, they need gonioscopy at least once a year. I think that's for all our glaucoma patients, and everything else there, you really got to do on a case-by-case basis. And then, of course, once you have a glaucoma diagnosis, or if you have a glaucoma suspect and you're monitoring them for long periods of time, you're checking for progression. So, of course, there's different types of progression. You can have a deepening or worsening of a defect, whether it's on OCT or visual field. You can have a widening of that defect, or you just have a new defect in a different area or in another eye. And then you need to always consider age-related changes, because as we get older, we do lose some axons, we do lose sensitivity on our visual field. And that's always very, very important when we're looking at progression. We're looking just at raw data ourselves. So you got to remember what is normal change. And then we need to consider variability that the instruments have when you take measurements. The glaucoma disease has variability. And of course, anyone that's done more than one visual field on a patient knows the significant variability of our perimetry testing in patients. Luckily, Zeiss created this guided progression analysis, which is available on both the Zeiss Sirius OCT and on the Humphrey perimeter, which it evaluates data in the context of variability. So it provides objective interpretation of progression. Because if you're looking at just at raw data, you might have a hard time figuring out, is this true progression or it's just variability based on the instrument or the patient. This Zeiss GPA data, it helps guide our management. It helps us answer questions like, is the patient's glaucoma worsening? If it is worsening, how quickly? Is it a fast progressor or a slow progressor? So it's important that if you have something like a fast progressor where you're losing 2 decibels of sensitivity on your visual field per year, in 10 years, you could go from pre-parametric glaucoma to advanced loss with significant effects on your vision quality. Whereas someone who's progressing very slowly, especially if they're a 90-year-old, 95-year-old patient with a shorter life expectancy, you might not need to intervene. It's going to help us sort of figure out, do we need to change our treatment? Because this GPA analysis can also extrapolate data. It sort of gives you this nice slope, which I think we have a few slides of that coming up, and it'll help you predict what the visual field parameters will be in the future.